AMD on OCT A. Welcome at you, Regina.
Thank you so much. So I'm going to be speaking on characterizing neovascular AMD on OCT angiography, and basically just looking at some of the heterogeneous features that we use in evaluating CNV both clinically as well as for clinical trials. Here are my financial disclosures. So some of the pressing questions that we have when we're evaluating OCT angiography for wet AMD is, what does OCTA do better than the standard imaging modalities that we have available right now? Are there features that we can extract that help us detect CNV prior to or better than standard imaging modalities? Are there features that we can use to follow patients up and to better inform us about treatment decisions? And then at the end of the day, does it drive better drug development? And are there ways in which OCT angiography may help us improve our patients' prognosis, either by treating smarter or by, by developing medications that help us treat these patients better? So all of us have heard about the advantages of OCT angiography over conventional angiography, right? It's non-invasive, it's rapid, you get structure and function from a single device. What really, however, is the sensitivity and specificity of OCT angiography when you're looking at patients with CNV? And that's an important question, of course, when you start using this as a screening tool for CNV, right? So studies have investigated this and have come up with numbers all the way from 50% to close to 100%. And although the studies vary in terms of their sensitivity numbers, one of the things that's consistent across studies is they can identify which CNVs are more likely to be identifiable by OCTA and which are not. So we know that it's challenging to identify CNVs in the setting of large subretinal hemorrhages, and that primarily has to do with the fact that OCTA signal or OCT signal overall doesn't penetrate very well past areas of large hemorrhage, and it's challenging to identify CNVs that lie under large pigment epithelial detachments. So one of my favorite studies that looks at the sensitivity and specificity of OCT angiography is the COFT1 study. It's a multi-center trial that was published out of Bailey Freund's group in New York, but a number of centers participated. And this was done in a very standardized scientific manner, where there were two readers that evaluated a patient's fluorescein and another independent two readers that looked at OCT angiogram, and this was type 1 CNVs only. And they looked at the sensitivity of the graders to identifying CNV, and they found that fluorescein and OCT angiography are about equally sensitive in identifying CNV. Both identify in about 67% of patients. But of course, keep in mind that OCT angiography always comes cross-registered with the structural OCT information, right? So when you provide that information, both the OCTA as well as the structural information to the graders, what you find is that the sensitivity of detection of CNV goes up. And so now we're looking at about an 85% detection rate for CNV. And I would argue that, now that we have available the flow overlays on the B scans, when you actually look at the flow overlays on the B scans and you're looking at structure as well as vasculature in the same image, this would increase your sensitivity and specificity of detection for CNV even more. And I think this is a study that's really begging to be done by anyone who's interested in doing it. So some of the other things that we monitor over time for CNVs is we look at the size of the CNV, we look at the area occupied by the CNV, and at a reading center level, we're very interested in this as well as at a clinical level, because often, especially in acute treatment, a reduction in the size of CNV is associated with a good treatment effect, right? Several groups have looked at that, and they've looked at the effect of anti-VEGF agents on treatment-naive CNV, and they found that if CNV is responding to anti-VEGF therapy, you'll typically see the size of the CNV shrinking. Now, when you're looking at this, both from a clinical and a reading center perspective, one of the things that you worry about is that we have all of these commercial machines out there, and all of them have different decorrelation algorithms and really are looking at different things when they're looking at CNV. And so are the measurements across devices comparable if you're getting different scans? For example, if you're getting a 6x6 scan versus a 3x3 scan, is the size that you're measuring across these scans comparable? And so we conducted a smaller study looking at this, It was really important to us from a clinical trials perspective to be able to comment on this. And what we found is that that surprisingly the CNV area is a very robust and a very repeatable characteristic, whether we look across devices, whether we look across scan sizes, and when we look at different time points. That we find that there's really no statistically significant difference, as long as looking at some of the commercial instruments that are out there. Now, there are other characteristics of the lesion that you can look at, right? You can look at these fine fibrillary vessels. These tend to regress as you treat patients with anti-VEGF, and certainly some people have suggested that, the presence of these fine fibrillary vessels is a marker of activity. So, that's one of the things that you can look at. Other people have segmented out the actual vessels within the CNV and have looked at the actual vessel, the actual vessel area within the CNV. Now, I would say that this is, just from a repeatability perspective, this is very, very sensitive to treatment effect, but it's probably not as robust as repeatable a characteristic. So a great research characteristic, but not as great for incorporating, for example, into clinical trials, because there tends to be quite a bit of variability, especially when you're looking at projection artifacts that arise from overlying blood vessels, or when you're looking at algorithms that subtract the projection artifacts and therefore may subtract out vasculature from within the CNV. So, studies looking at this have shown that it's very sensitive, but maybe not as repeatable and as robust as something like CNV area. Now, one of the other things that has been investigated by our group and by other groups in evaluating CNV is to look at CNV volume. And total volume of CNV can be reconstructed from the individual en-face images or the individual B-scan images, indeed, that you get on these patients. It's somewhat confounded by the fact that because the vessels within the CNV have projection artifacts, that the volume of the CNV, that the vertical extent of the vessel tends to be exaggerated when you're looking at OCTA images. But eventually, I think with the development of better projection artifact removal techniques, that this may well be the metric that we're looking at rather than looking at area, because of course, as you all know, the CNV is not a two-dimensional structure. It really has a three-dimensional aspect to it that is very important when you're looking at treatment effect of CNV. Now, some of the other parameters that are not out there in our machines as yet, but maybe coming up in the near future, are looking at the size and the flow within the blood vessels. And I presented on this in some detail in another session yesterday. But certainly one of the things that we notice is that CNVs tend to consist of these central core or trunk vessels. And when you look at the flow speeds of blood within those core or trunk vessels, you find that these trunk vessels have very high flow speeds. And along the margins of the CNV, you have these smaller blood vessels that have very low speeds. And the low speed blood vessels tend to be the ones that are more sensitive to anti-VEGF therapy versus the ones with higher speed, and the core vessels tend to be the ones that are more resistant to treatment. And so, just from the, again, clinical trials perspective, this may potentially be one of the things that you could screen out for to identify patients that are more susceptible to therapy, as well as patients that are more resistant to therapy, and see how they respond to the various different therapeutic agents that are coming out in the clinics. So what about CNV response to therapy? And Bruno Lombroso and David Wong's group have produced these very nice sequential images of imaging patients a few days after therapy. And what they found is that about a week to 2 weeks after treatment is probably the time when you see the maximal regression in the size of the CNV, and that after that, the CNV tends to grow. And what they have found is that reaccumulation of fluid lags behind growth in size of the CNV. So again, size of the CNV and seeing it contract and then seeing it expand again may be a more robust parameter to guide treatment, especially if you're following a treat and extend or a treat as needed characteristic or treatment design, that it may be more useful to look at the actual size of the CNV and see how that changes rather than looking at fluid reaccumulation, which tends to lag behind and is a secondary rather than a primary characteristic of the CNV. And of course, on follow-up, some of the other things that we have been looking at and that may be useful in the future are looking at choriocapillaris vessel density maps and seeing how these are altered in the area around the CNV and how these alter in response to treatment of the CNV. So then we come up with this interesting scenario, right? That we have a modality that's really very sensitive to the detection of CNV, and we start getting these patients in our clinic, such as this patient of mine. He's a 58-year-old Asian man who we followed up for several years for dry AMD. He's coming in for his annual visit on OCT B scan. He has his usual lumps and bumps. Visual acuity is stable where it's been all along, and he has bilateral cataracts. And we do an OCT and an OCTA on him, and we find that he has these subclinical, non-exudative, subretinal type 1 CNVs. And these have been described, I think they were first described by Phil Rosenfeld's group and have subsequently been described by several other groups. And really almost 1 in 10 patients with dry AMD who don't have exudation may have these subclinical CNVs that underlie these lumps and bumps that you see in the retina. And so what to do with these patients? And it's an interesting question. I'll give you, some of these hold stable for years, and I'll give you an example of a patient of mine. I first saw him in November of 2014. We started seeing, on that very primitive OCTA machine that we had at that point, some vascular changes underneath the retina. Visual acuity was still 20/25. Followed him up for a few months. You see the vessel changes increasing. The patient is seeing 20/30 and is doing really well. Came back in about 6 months out from the initial presentation, and you see that the CNV is much bigger. At this point, the patient has subretinal fluid and has some loss in vision, as you can see. We treat him and you see the CNV regress, but with successive treatments, you see that, even though the patient does very well visually and is dry on standard OCT scans, we see that this arborizing network is continuing to grow underneath his retina. And so, the question always arises, what happens when you identify these patients? Do you start treating them early? Would early treatment have made a difference, or would early treatment actually have handicapped this patient and sent him along the pathway of geographic atrophy, whereas as of right now, they're doing really well visually and are well controlled on standard anti-VEGF therapy. OCT angiography is providing us with some very interesting and useful parameters on CNV. I think we're still learning as we go along about how these may be integrated into clinical trials and how they may guide our therapy of patients with CNV. I think certainly OCT angiography enables us to detect CNV prior to and potentially better than other standard imaging modalities, possibly allows for better follow-up of these patients, but we're still working on how it will alter our treatment paradigm in these patients, and eventually if it'll lead to better prognosis for our patients with CNV secondary to AMD. So still an imaging modality in its infancy, but I think we're right at the point where we've stopped looking at this as a shiny new car and are starting to see that it really does represent to a large extent a paradigm change in the way that we're looking at our patients with CNV and following them up over time. Thank you.